I'd like to start first by, thanking all our pediatric residents, to all my COVID-19 warriors, and to all my wonderful CAFAB pediatric residents. Would like to say thank you for their excellent support, collaboration, and commitment. I'm so proud of you now and always. Keep up the great work that you have been doing, and please be safe. Okay, so the objective of the presentation is going to be about the use of a physiological approach to understand the pathophysiology of Meconium aspiration syndrome, recognize the clinical symptoms and radiographic pattern in MAS, and understand the management strategies for MAS in neonatal unit, and to look at the management and identify potential for complication associated with Meconium aspiration syndrome. But my focus is going to be more on kind of tying the physiological aspect of the disease in order to optimize our management. So Meconium aspiration syndrome is defined as the respiratory distress in newborn infants, born through meconium stained amniotic fluid, and whose symptoms cannot be otherwise explained. And it can present with varying degrees of severity, from mild to a life-threatening respiratory failure. And the meconium stained amniotic fluid has been noted in approximately 10 to 12% of all the deliveries, and it varies from center to center and from country to country. And the risk for Meconium aspiration syndrome and the meconium stained amniotic fluid is greatest in the post-mature, small for gestational age infant, as well as in vaginal breech delivery. And I think we are seeing less of severe cases of Meconium aspiration syndrome because of the optimization in the both obstetric and neonatal practices. Identifying high-risk pregnant ladies, kind of optimizing the timing of the delivery, and also from the point of view of neonatal intervention. So the incidence of the stained amniotic fluid, it's the incidence, it starts from the nadir at 31 weeks, after which the incidence increases with gestational age. And it goes up to 5.1% in the preterm. At one time, we thought that preemie do not present themselves with Meconium aspiration syndrome, but we've seen few cases. Term 16.5, the post-term is 27.1%. And there is some ethnic, higher in the ethnic variation, because it's higher in the Black and in the South Asian infant compared with the white population. And sometimes it's difficult to know whether it's really racial differences, or it's the availability and the accessibility for healthcare services. Now, what we're going to talk, because we're going to focus a bit more about the pathophysiology. So we're going to talk about the composition of meconium, the meconium passage, the aspiration, and then we're going to spend more time on the impact on the pulmonary and the airway. And why? Because I think if you understand, the physiology and how does it affect the, the kind of the pulmonology, physiology, then it would be easier to design the right therapeutic intervention. So now meconium, it's present in the fetal intestine during the 3rd month of gestation. Meconium is sterile, but it is not, it's pathological. Why? Because it has a high surface tension. It's not meant to go into the lung. It stimulates the release of cytokines in the lung, as well as the pancreatic phospholipase A2, which has a deleterious effect on the lung, and it causes injury. It stimulates apoptosis of the cells, and this is really interesting because you know, it stimulates the death, the spontaneous death of the pulmonary cells. And that's why, you know, kind of there is a damage that maybe sometimes it's unrepairable. And now there is a new future kind of outlook for the treatment of the meconium aspiration that addresses, you know, how can we, you know, stop or prevent apoptosis. It's also a potent inhibitor of surfactant, which is important point, you know, when we are looking at the management. And then it's a good culture medium for GBS gram-negative bacilli. So though it's sterile, but especially the bile salts encourage the growth of bacteria. Now let's talk about the meconium passage. So the passage of meconium occurs in the first trimester, and the fetal defecation slows after 16 weeks gestation, and then it is activated again between 34 to 35 weeks. And if we look at, you know, the anatomic and the functional maturation of the GI tract, you'll find that the meconium start being passed in the fetal life at around 35 weeks. Of course, passing the fetus's meconium passage is more in the term and the post-term baby fetuses. And, you know, the fetuses that they pass in utero meconium, they had a higher motiline level in the cord blood. And motiline is one of the local GI hormones that stimulates the parasympathetic tone, and it's actually released, and its presentation is exaggerated when the fetus is exposed to hypoxia. And on the same wavelength, also, if there is an incompression of the umbilical cord, that causes, you know, increase the vagal outflow through the sympathetic stimulating the parasympathetic inflow and causing hypoxia. And you know what, this is really interesting, because if the baby, if the mom or the fetus, they had, you know, asphyxia for, you know, hypoxia for any reason, it is mediated through hormones. And, you know, in any type of stress, the maternal hormones are released, you know, which we know them, the noradrenaline, adrenaline, the adrenaline and the glucocorticoids. And, you know, when they pass through the placenta, they stimulate the corticotrophin releasing factor from the placenta. And the same thing if the fetal was exposed to any type of stress, you know, I mean, decreases blood supply through the placenta. The same thing, that stimulates the release of the placental corticotrophin releasing factor. Now, this corticotrophin releasing factor, what it does, you know, it has two types of receptors. So it stimulates receptor 1, which are present on the gut, and is stimulating the parasympathetic nervous supplies there, leading to increase in the motility of the gut, and hence passing meconium. So yes, we do worry about the meconium passage, but you know what? Meconium passage is really a sign rather than a symptom. So it's a sign that the fetus has been exposed to, you know, hypoxia or stress, or, you know, the fetus was not really having a good in utero environment, and that's why the meconium passage. So usually babies who have suffer a lot with the meconium aspiration syndrome, you know, their underlying reason, it's not because the meconium itself, it's just because what caused them to pass the meconium. So usually they are acidotic, and that acidemia that they suffered secondary to hypoxia in utero is the one that get them in trouble. Added to that as well, the meconium that they aspirate. So now let's talk about aspiration. Why should a fetus aspirate? Because we know that fetal breathing movement is there, and it is detected as early as 10 weeks of gestation. And fetal breathing occurs for 10 to 20% of the time at 24 to 28 weeks, and it increases to 30 to 40 after 30 weeks of gestation at the respiratory breath rate of 30 to 70 breaths per minute. And then they can have a period of apnea that goes up to 2 hours. But if the fetus suffers more frequent and prolonged periods of apnea that they're not considered physiological, then that baby is at high risk, to have hypoxia and even, fetal death if it was not, kind of identified. And so that means that that's a fetus in a very hostile environment. Fetal breathing is inhibited during quiet sleep, and the breathing itself, it helps, in movement of the fluid between, it comes out from the baby's GI, from what comes from the renal system, what also comes from the placenta, and that's what the amniotic fluid. So, and also plus to the secretion that it is secreted by the by the tissues that they're covering the respiratory system. So all this causes like a to and fro movement of fluids that goes through the respiratory system. And this to and fro movement is very important because what it does, it actually helps in the lung growth. So if you think, the babies, for example, that they have tracheoesophageal fistula and, they have atresia, for example, that to and fro movement is not there. So that's why they have, kind of that would affect their maturation of the lung. So yes, it's, and also, kind of the differentiation also of the type of the cells. So, there is more distension of the alveoli, then there is, that would stimulate the differentiation of type 1 cells lining the epithelium into the respiratory alveoli into type 2 cells as well. That is responsible for the production of surfactant. And, this is really an interesting fetal breathing of the amniotic fluid in colored Doppler, and it shows that the fluid goes in and out. So if the fetus passes meconium, so then there is a great chance that that meconium, because of this to and fro movement, that would go into the the respiratory system. Now, would it cause damage on its own, or could be that if there is too much meconium there, like we said before, it's rather a sign rather than only a symptom. So now let's talk about the pulmonary and the airway. So what happens, the pathophysiology is that, meconium is in the tracheobronchial tree. It will inactivate surfactant, as we just said, so that meconium, is not very friendly to surfactant. It causes, chemical pneumonitis, and it causes airway obstruction because, it's thick and it's thick, so it can block the alveoli either totally or partially. So the end result will be atelectasis because of the obstruction, or if it's not totally obstructed, then it will be like a ball and a soccer. So it will be, kind of a hyperinflated alveoli. And when they are hyperinflated, they can actually push and causes atelectasis on the neighboring smaller alveoli. And if we don't have surfactant, then, and Neonates, then the end results will be atelectasis, ventilation perfusion mismatch, hypoxemia, acidosis, and pulmonary hypertension, which plays a role, a very important role in defining the severity of the Meconium aspiration syndrome. Now, I'm going to take you now to what we have discussed before. And I don't know whether you guys remember, but we've talked about how can we look at neonatal pulmonary diseases from the point of view of physiology. And we're going to focus now on the Meconium aspiration syndrome, and we're going to discuss the compliance, the resistant, the time constant, the functional residual capacity, and the ventilation perfusion mismatch. And why? Because then we would know what would work and what would not work in kind of managing those patients. So let's start with the compliance. Now, compliance is because compliance is what is, as you know, that the airfield spaces, they are coated with water, and they have a high tendency to collapse because, they kind of stick together. So they pull the surface together. While, when we have surfactant, what surfactant does, it's a lipid from a monolayer that it's actually manufactured by the type 2 cells, and then it spreads like a carpet on the, on the surface of the small alveoli, decreasing the surface tension. So the lung, instead of instead of being very low compliance, because the lung, instead of being collapsed and unable to distend because of the lack of the surfactant, with the presence of the surfactant, then it will distend in order to be able to do gas exchange. So this is an important curve that I would like you really to focus on, which actually describes the relationship between the pressure and volume. So it's like how much pressure you are going to put in order to inflate the lung. So if you see as this one atelectatic lung, it doesn't matter how much pressure we are putting. So even with the pressure of 30, even up to 35, the only volume that we can get is not more than 0.5 milliliter mils. While in the other lung that it has, the surfactant lying it, and then, the compliance is better, you find that even with the, kind of a pressure of 10, that the lung is opening up, and then, to do the inflation and then the deflation. So we've just said that there is a problem with the surfactant inactivation when we talked about the Meconium. So Meconium inactivates surfactant. And not only that, it produces as well it stimulates cytokines that causes destruction, and, it can kill neonitis. So yes, of course, the compliance will be lowered in the Meconium aspiration syndrome. And yes, you can see that, you can say, well, it might not be. Yes, it might not be, depending on the severity and the amount. And remember what was the underlying cause as well. Now, let's look at the resistant. So we have the other one, which is, okay, the resistant. So according to here, the resistant is high. So what is that resistant? We talked about it before, that we said that the respiratory tree, we have the conducting zone, and we have the transitional and the respiratory zone. So the conducting zone is trachea, bronchi, bronchioles, terminal bronchioles, and in those, and these are the different generation. And in here, it just conducts air. And then we go into the smaller, which is the respiratory bronchioles, the alveolar duct, and the alveolar sac. And, and this goes up to 23 kind of generation. And this is where most of the gas exchange take place. Now, the resistant, it depends on what? It depends on the viscosity of whatever goes through the tubing, and it's inversely proportionate to the radius, and it's directly proportional to the length of the tube. Let me just close the door because there is a bit of noise. Excuse me. Sorry about that. So let's go back. So imagine that you are watering the plant in your garden, and then you have a hose, which kind of you're watering your flowers, and then the longer the hose, then of course would be the more resistant. And when you try to increase, the water flow in order you want to, kind of like spray them. So what you do, you put your thumb on the opening of the hose, and in this way, actually, you are decreasing the radius. So when you're decreasing the radius, you are increasing the resistance, and then you are increasing the gush of air, the gush of water. So it's kind of the same thing. So we are expecting, if we just take this for granted, then we're saying, well, okay, this is the bigger radius, okay, and kind of longer. So this means the resistant, so where should be the resistant higher? Should be the resistant here or the resistant here? Is there anybody to answer? Well, okay, so I guess not just one way. All right, so what we see here is that with airway generation, the higher the airway generation, the lower is the resistance. But you're going to tell me, but that's exactly the opposite of what you've just said. The resistance should be higher here rather than here. But the resistance here is not per one alveolar and one alveolar sac and one respiratory bronchioles, but it's cross-sectional. So we have so many of those. So when we take them as a cross-sectional, so the cross-sectional radius of all of those is much higher than the cross-section of a bronchi or a trachea alone. So then the resistance is lower here than there. So how can we kind of put this in the context of the meconium? So meconium, what it does, it blocks, those two. It blocks here either totally or, partially. So when it blocks them, what does it? Then it will increases the resistance. Okay, and that's what we were talking about. And this is also airflow. Sometimes if you have mucus, it could be as well meconium, and even the trachea or the bronchioles, then you are changing the airflow from being laminar into a turbulent. And when you have a turbulent airflow, this means that it's more resistant. So then we agree that the compliance is low, okay, and the resistance is increased. Now, what about time constant? Time constant, it equals, time constant, what is the, let me just remind you with the time constant. The time constant is the time that, air needs in order to travel and to get an equilibrium between, outside the mouth to the smaller alveolar sac. So it's like from the mouth up to here. So this means that the air is going to travel through what? Through all the airways, which are equal to resistant. And then as well the compliance, because the stretchability of the lung will also affect the progress of air during inspiration and during expiration. And anything that would affect either or both would affect the time constant. So here, for example, during inspiration, so how many time constant you are going to reach to an equilibrium of 99%, so you have with one time constant, you're going to reach to 63, 86, 95, 98, 99. And it varies. If there is any obstruction of getting an equilibrium, with 5 times, or you need more time, this means that your patient is going to be hypoxic. And if we are taking a longer time to do our expiration, and this means that we're going to retain more air in our alveoli, which is going to interfere, which is going to increase our functional, which is going to cause more air trapping. So having said that, and we've just talked about the Meconium aspiration syndrome, so we said that the compliance is low, but the resistance is high. So how would that affect our time constant? So this means that the time constant is increased. So you say, okay, so what we're going to do with this information? That information might be important when you start to ventilate those patients, because usually when you ventilate prematures or babies, you have to kind of decide on your inspiratory time, and you have to look into the lung pathology, according to the disease that the baby went through, unfortunately. And also in order to design, and also you have to look at well as your chest X-ray and the pulmonary graphics as well. So now we want to move to the functional residual capacity. So what about the functional residual capacity? Okay, let's start with the tidal volume. Tidal volume is the regular breath that we take in and out. So the volume of each breath is 5 to 8 mL per kilo. And when the tidal volume is low, this means we are hypoventilating, we're being hypoventilated. And when it's high, then there is an overdistension. And it should be kind of equal with inspiration and expiration. So this is the tidal volume. So now, what is the functional residual capacity? So the functional residual capacity is the volume that remains at the end of the tidal expiration. And it's the lung volume at which the respiratory cycle, kind of starts. And the optimum value, it is about 40 of the total lung capacity, 30 to 35 mL per kilo. So why it's important? It's important because, at the end of our inspiration, we don't want to collapse our lung and start with a very high pressure again to inflate it, as the baby does with the first breath. So functional residual capacity, it has to do with the, kind of compliance and making sure that, you don't collapse your ribs, at the end of the expiration. Now, okay, it's good to have it like 40%, but what about if it's more than that? Well, let's look at this X-ray. And this X-ray is for a patient who had a severe Meconium aspiration syndrome, and I guess also suffered from whatever intervention that was, carried out, ventilatory strategy. And if we look here, how do you expect this patient's functional residual capacity? That baby's functional residual capacity is quite high. Why? Because look at that, he's trapping air all over. And then this means that his functional residual capacity is it's not here, it's actually moved forward, which means that his tidal volume is becoming more and more smaller. So if you think about those babies breathing, and they have a high functional residual capacity, usually their breath is quite, kind of shallow. Why? Because their tidal volume has been affected because of the increase in their functional residual capacity. Now, there's also, when we see this X-ray, what do we think? Oh my God, this is a hyperinflated lung. And there is a good relationship between the lung volume and the, PVR. So when the lung volume increases, then the PVR, it increases. So if we take it and then we put it, we say, okay, how can we put it actually in kind of patient scenarios? For example, if the lung is atelectatic, like in pure surfactant deficient lung, So you're going to find that the lung volume will be here. While if you have a lung that is hyperinflated and with air trapping, like the Meconium aspiration syndrome, you find that the lung volume is here and the resistance is here. So we can ask why the resistance is increasing. Because, with each scenario, ideally the lung volume will be here, because in this way, that's the area where it's optimum, because when we have this, then the pulmonary vascular resistance is not going to be high. And that's important in order to maintain, ventilation and gas exchange and so on. So what happened here and what happened here? So we have vessels, those small capillaries that they are in between the alveoli and between the small alveoli. So when they are atelectatic, these capillaries are, kind of squashed. So they are obstructed. They're obstructed. There is, so the resistance is increased. So because the radius is narrowed, so you know what? They're going to increase the resistance. While now, when the lung is extended, what happens? So when they are extending, they are obstructing the larger vessels that they are between the loops. These vessels that they are in between here, they are obstructed. So when they are obstructed, the same thing, you are making the radius smaller, so you're going to increase the resistance. So either atelectatic lung or hyperinflated lung, both of them will increase the PVR. And we don't want that. We don't want the PVR to be higher. Why? Because when it's high, it's going to be difficult to, kind of transit into, the physiological, pulmonary, postulated circulation. So now we have the ventilation perfusion. So let's look at about that. What is the ventilation perfusion? All right, so matching and mismatching. So all of us, we have an anatomical dead space, and this anatomical dead space is in the conducting zone of the airways, because there is no gas exchange. And then we have the physiological, dead space, and kind of the physiological dead space. You can say, for example, you have healthy and well, human being. For example, if they are standing up, for example, the upper zone of the lung is ventilated better than perfused, while the lower part of their lung is perfused better than vented. So yes, there is some mismatch there, but with healthy movement, I think it's quite balanced. So if we lie down, then our anterior part is ventilated, while our posterior part of the lung is being perfused. So there's some type of mismatching, but if there is healthy and well, then kind of it's kind of more of a physiological. So the dead space is anatomical plus physiological, and we don't worry about it as long as the human being is healthy and well. But for example, if that's what you see in adults, especially in adults, it's of a great value that when they keep moving the patients, because they are trying to recruit, because of the, recruiting more and more alveoli. And we do have a similar issues sometimes in neonates. We keep, kind of turning them different positions, but it's not as, kind of a very important strategic ventilatory strategy as it is in the adults. So, what happened with the ventilation perfusion, matching and mismatching? So this is what explains it. For example, the A, here you have the alveoli and you have the blood flowing pulmonary capillary. There is no obstruction here or there, so this is a ventilation perfusion match. Well, if we look here, we find that there is, the pulmonary capillary, there kind of, there is no obstruction for the blood flow, but there is a problem with the ventilation here. So the alveoli are blocked. So we can think of that as meconium. So we have a meconium that is blocking here. So it would create a ventilation perfusion mismatch, because here it's 1 and here equals to 0, because it's 0 ventilation over whatever perfusion is. 0 divided by any number equals to 0. Now, if we look at the third one, if we have a well-vented area, alveoli and alveolus, but at the end, the blood is not really flowing, it's obstructed. It could be, you know, if you have a hyperinflated lung, you could, for example, squash the pulmonary capillary and kind of disturb the blood flow. So you could have as well as ventilation perfusion mismatch. So is that applicable to Meconium aspiration syndrome? Yes, it is, because they do have, you know, as we said, that there is a blocking of the alveoli, of the alveolus, and thus they have a ventilation perfusion mismatch. Okay, so at the end, what would happen? So we said that they're going to, surfactant would be decreased, so that would decrease the lung compliance, decrease the alveolar ventilation, decreases the pulmonary blood flow, decrease lung metabolism, and, you know, even the endogenous surfactant would not be, you know, manufactured, because remember, surfactant manufacturing is an active process. It's done by the type 2 cells, and it requires oxygen. I mean, it requires energy. So if it's not there, then here we go. That would be a vicious cycle. And, you know, that would be no oxygenation. Then there will be pulmonary vasoconstriction, pulmonary increase in the pulmonary vascular resistance, decrease in the pulmonary blood flow, right to left shunt through the foraminal valve and the duct, and hence, you know, it's another, you know, vicious cycle. So after we've known, and, you know, kind of what's the physiology, what's the physiological, you know, kind of problems that we have with the Meconium aspiration syndrome, and what could lead the end product. And this is, you know, what you see. This is purely at, you know, the two different X-rays, and if we could just take it as a test here. So what do you think? We have 2 X-rays, X-ray 1 and X-ray 2. Let's try to match them. You know, though, you know what? Let me just remind you, you know, usually the scenarios is not just either this or that. Sometimes it's a combination of both. For example, we're saying the Meconium aspiration syndrome, it can be a combination of compliance and resistance. So, and also we have areas that it could be hyperinflated, and another area that is atelectatic. So it's not all or none, but what is the most likely? So if you look at number 1, which one do you think? So this is a totally atelectatic lung. It looks more of like hyaline membrane disease. It could be also as well as meconium. We keep saying that it's, you know, kind of more of an air trapping, but not necessary. Yeah, would be, I mean, yes, sometimes you see air trapping, you say, you know, it's more likely to be meconium. But I think you have to take the whole scenario together, because they can be atelectatic as well. So which one it is? This is definitely not A. In atelectatic, there's no ventilation, so most probably this is B. And this is, as you can see, it's a hyperinflated lung. And, you know, that could be a combination of, you know, of C as well. That could be C as well. Now, if we look again at the, you know, pressure volume, because again, I want us to, I would like if we always look at the disease from, and describe it from that point of view, because then it would be easy to match our intervention from a physiological point of view. So here is, you know, the pressure volume that I told you. This is the most important, you know, curve in neonatology. So as you can see, we have A, B, and C. So A here is a very low functional residual capacity, and there is more of atelectasis. And C, we have a high functional residual capacity and there is an over expansion, while B, there is a normal functional residual capacity here. So what do you think of here? And what do you think of this? So A, which part of the curve it is represented? It's most probably it's A. I mean, it's a very low functional residual capacity. It's atelectatic, and the volume of the lung is kind of is very low because of absence of surfactant. And then here it's like a kind of peaking because it's hyperinflated, and so it's most probably a high functional residual capacity and overexpansion. And this is the penguin peak, which we see it on pulmonary graphics. I'm going to throw something else on you, but please keep it in consideration because, sometimes you start the management and you don't know which way you're going. You have to kind of have a certain criteria in your mind or certain values in your mind that helps you in addressing how the progress of your patient and whether I should kind of change my strategy, strategy to a better one, or because the patient's not doing well. So here are some of the oxygenation derangement that helps us in making decision, even for certain medication, even starting certain medication, it helps us. So the first one is the alveolar arterial oxygen tension gradient, and it increases with worsening oxygenation. Oxygenation ratio, which is really simple. It's the PaO2 divided by the FiO2, and it decreases with worsening oxygenation. And then the oxygenation index, which increases with worsening oxygenation. And all of them, it actually reflects the severity of whatever ventilatory mode you're using. You're having a higher MAP, a higher FiO2 requirements, and a lower PaO2, so that reflects that the disease is severe. And also it helps you when you communicate with others, especially if you've decided that the patient needs to be transferred into a higher, intensive care unit. So it's good to kind of having a common language. So if you say the oxygenation index, it's 30 or 40, that reflects on the severity of the disease. So now that we're finished with the physiology and trying to see what is the management plan for this patient would be, we're going to talk a bit about the clinical presentation. So like we said before, there could be none, it could be severe respiratory distress, hyperinflated chest, perinatal hypoxia, pulmonary hypertension, and usually there is remember when we've shared together the atelectatic lung, I told you that it could be also meconium, but you get the clues from the obstetric history that there was a meconium stained amniotic fluid, passage of meconium noted at the delivery of that meconium staining of the infant. Air leak is quite an issue, and these are some of the x-rays that it's very important that to rule out in, so the first x-ray is very important, and the earlier you do it, the better, because you want just to make sure that there is no air leak that you need to address it immediately. So here, as you can see, they're really kind of horrible. There is air leak, in the whole mediastinum, here in the pericardium, and here there is a bilateral pneumothoraces. And this one, it can be as well, meconium aspiration syndrome. So diagnostic, we said we're going to do the X-ray. Of course, we're going to do our blood gases, and blood gas has a whole. We need to have a whole session on the blood gas. Maybe we should do that with cases. I think it makes better sense than just going through it. So just like that. So the baby could have a normal blood gas, or they can have hypoxemia, hypercapnia with metabolic acidosis. So it can be a combination of all of the above. It's very, very, very crucial for these for this type of patient with meconium, kind of aspiration syndrome, that you have to have a continuous oxygen saturation, and you have to keep it really high, because you know what, there is this transition that the baby is trying to transit into the normal, from the fetal circulation to the normal circulation. That's if there is any period of hypoxemia that the baby is exposed to, then that would not facilitate that transition at all. So that's why it's important to keep to monitor saturation and make sure that it's high. Preductal arterial partial pressure of the oxygen between 60 and 100. Oxygen given to the infant should be titrated according to the preductal saturation, and a different 10% or greater between the pre and the postductal saturation is suggestive of pulmonary hypertension. So what are the other things that we do as well for the babies? We do chest x-rays, we put lines, and it's always better to put a UA and UV line. Meaning you can put as peripheral arterial line, that's okay as well. But you need really to have a good lines and a good mode of monitoring the blood gases, and a good access in order to give fluids and medication. They become quite challenging really to do that. Of course, what you need also to do sometimes echo, but would you do it so early? Would you do it later on? It's according to the judgment of the of whoever is taking, according to the situation. Echo is very important as well, because it gives an idea about the severity of the illness. It gives you an idea if there is a pulmonary hypertension. It gives you an idea if there is a load on the right side of the heart, and that you really need to take care of. And now with the functional echo, it helps us as well in order to monitor the hypovolemia, and whether it's a hypovolemia issue or it's a contractile issue, cardiac contractility issue. So what are other management plan? Of course, supportive care is very important, which we talked about it, which is hypothermia should be totally avoided. Should not be hyperthermia either. It should be normothermic. So this is important. Baby has to be comfortable, limit the noise level and also the intervention, because that's a very critical stage for the baby, and you want that baby to pass to the normal transition. So minimize, noise and the intervention, noise and quiet, don't really flash the lights in the baby's, eyes and so on. And then, like we talk about the access, we talk about, whether you need to do a rule-out sepsis workup. And we're going to talk about the antibiotics now, later on as well. And we're going to check the glucose, we're going to monitor the blood gases, and we're going to start IV fluids, see, very important to have the lines as well. Sedation, maybe you need to sedate the baby. Maybe you can do it, without medication if it's needed. Then minimize it as much as you can, and paying attention as well for the blood pressure, which we're going to talk about it as an important area of concern. Now, oxygenation and ventilation, as we know, we have different modes of ventilation. We have the CPAP and IPPV, we have the assisted mechanical ventilation, and we have the HFO. Now, that we talked about the physiology of the meconium, aspiration syndrome, and we said, what did we say? we say, okay, this is now the description. So Meconium aspiration syndrome has a low compliance, high resistant, increased time constant, increased functional residual capacity with a ventilation perfusion mismatch. So now I want to design an intervention that would correct these things. Again, that varies from one baby to another and from one scenario to another. So, we might argue, well, are we honestly going to talk about, are we honestly going to talk about CPAP? Because, CPAP maybe is not the best tool to use it on the severe meconium aspiration syndrome. Well, kind of, yes. I mean, many people will agree on that, but still, there is a role of CPAP in the management of meconium aspiration syndrome. Why? Because CPAP is very simple. It actually stabilizes the airway diameter. It stabilizes, the surfactant function and metabolism. It's actually protected because by maintaining breathing while the baby is on, the CPAP, actually the to and fro, the inspiration and expiratory movement of the small alveoli helps in releasing surfactant. Also, it stabilizes the chest wall and the chest compliance. It reserves the functional residual capacity, and it improves the the pressure volume curve. Okay, so like we said, it helps as well with the venous return, ventilation perfusion matching. It helps with the surfactant release, and it helps us in observation on how we can observe the patient. Now the problem is we have to know at the limit, and we have to know what to expect. And now we've just said that, functional residual capacity already on that baby, it's high. So, so this is one thing. Am I increasing the risk of pneumothoraces? Because there is a risk with pneumothorax with CPAP. And it differs from one study to another. I think the Columbia group, they always, kind of maintain a pneumothorax level less than 2%, even with meconium aspiration syndrome, while elsewhere it goes up to 9%. Nasal obstruction, nasal septal erosion, abdominal distension. Now, abdominal distension might be also a challenge. Why? Because remember that when you are the Laplace law, that when you look at this, I mean, this is like an intestine, which is like the CPAP, air in the whole intestine. And if you look here, you'll find that you are increasing the diameter. So when you are increasing the diameter of the abdomen, you are interfering with the ability of the contraction, of the contraction of the diaphragm. So that might be one of the issues that you might consider with using a CPAP on a meconium aspiration syndrome. And then you have also to put a criteria how much oxygen I'm going to tolerate. Am I, like in our unit where we're kind of go not above 30%. If the patient required more than 30% on CPAP, then most probably, we need to start some other intervention. If there is frequent A's and B's, there is more and more retention of CO2. FI2 requirement here, we put it as 0.5, but like I told you, in our unit, we take a lower FI2, intractable metabolic acidosis and marked retraction. If there is air leak, of course, then we need to shift them to something else. So reasoning for intubating, worsening clinical distress, increased oxygen requirement, hypoxemia, acidosis, clinical instability, and intolerance of CPAP. So then assisted mechanical ventilation, that's kind of a big subject to go through just like that. And yes, we can say which is like the evidence for this is better than the other one. But remember, when we talk about ventilatory intervention, it's actually operator dependent, and units have more experience with one wave versus the other. That makes them more expert, and everybody feels would do a better job with it. So I think it's all depends on the experience and experience of the unit. And when I say experience of the unit, it's not only doctors, it's doctors, nurses, RTs as well. So we'll start with the intermittent mandatory ventilation. This is, I mean, it's history. Nobody is doing that, which is, but it's like the kind of the beginning of the ventilation. So it's, it's kind of time cycled, pressure limited with delivery of mechanical breath at a present interval, irrespective of the spontaneous respiratory effort of the infant. So, this is the normal breathing, and this is the machine delivering the pressure. This is the inspiratory time, and this is number 3 is the PEEP, and this is the PIP, and this is the and this is the driving force between them. Okay, so let's go back so we can see it. All right. So here, as you can see, between there is no synchrony at all. It's kind of if the baby is lucky, he might synchronize with the ventilator. So the ventilator has nothing to do with the patient. The patient has nothing to do with the ventilator, and both of them, there is no harmony. So this is quite harmful, and I'm glad that nobody's doing this anymore, because, babies used to be sedated, paralyzed in order for the machine to take over, and that produced a lot of harm. There was a lot of barotrauma, and, it was difficult to kind of increase ventilatory days. So it's not the best practice. So the new machines, there is a harmony between the baby and the machine. So actually the baby tells the machine what he or she requires, and then accordingly it is delivered. And this is what is called as assist control. So this means that there is kind of a way that it's not like a magic. There is the machine detect either the flow or the pressure of the normal spontaneous breath of the baby, and then it send it to the machine as a signal it to the machine, and then the machine send the the ventilatory support, timing it with the baby's breath, so augmenting it, and this is what you see here. Okay, so here we are augmenting all the breaths, and you can see this is what we call it, synchronized. It's assist control ventilation, and there is so many different parts of it, different types of it, but that's the principle. And then we have the SIMV. SIMV, I think, is getting out of favor now. It can't be used. It can be used with weaning, which means that I'm going to synchronize not all the the breaths of the baby. Maybe I will synchronize 50%, 40%, 30%, and then slowly you can, wean. It's used as mainly a weaning tool. Now, volume triggered ventilation and volume ventilation ventilators are there to stay, and there are more and more evidence that if they're better for to deliver irrespective of the pressure needed to do so. So there is a predetermined volume of gas, so it's less harmful maybe for the baby, and it automatically means that PEEP as compliance improve. So now we could use the, kind of the mechanical ventilation, more likely to use the assist ventilation. And, if still the baby is not responding and then requiring higher FiO2, and we're seeing more and more, PIE changes, and we're seeing more kind of PIE and more retention of CO2 and respiratory acidosis. And I think this is the time to shift to high frequency oscillation as a rescue. And it's kind of, if we simplify it, we say here with the mechanical ventilation, with the IMV and assist control and so on, you have a PEEP, you have a PIP, you have an inspiratory time, you have a rate. But here what you have the map, and then around that map, what wiggles is the delta P, and the map get care of the oxygenation, and the delta P take care of of the CO2. That's more simplifying it, but we need a whole lecture in order to go into the use, and maybe if you're interested we can do that. But there is something, usually the high frequency, they work better with the homogeneous lung field. Homogeneous lung field, which means that it's either atelectatic or it's either hyperinflated. If it's a PIE, pulmonary interstitial emphysema, then if it's bilateral, it works better. It works better in the homogeneous rather than the non-homogeneous. And Meconium aspiration syndrome is considered a non-homogeneous, but it doesn't mean that it's not used. It is used, and it is used, like we said, as a rescue treatment for the severe Meconium aspiration syndrome that does not improve with conventional ventilation. And you might need to sedate, and of course, control the pain. Should be maintained in infants with severe Meconium aspiration syndrome, especially the one that you suspect that they have pulmonary hypertension. And again, how you decide which way to go. Remember the oxygenation derangement. You have to keep it always the back of your mind. Am I going into the right direction? Do I need to change my, my kind of plan of care? Maybe, the patient is not responding. And always when you think of that, then you have to think what I'm trying to do. I'm trying to reach nearly normal with whatever ventilatory goal. I don't want to under atelectatic, and I don't want to overexpand. And you know what? We have always to keep in our mind that if there is hypoxic respiratory failure, we investigate, establish a working diagnosis to treat accordingly, optimize conventional respiratory support, and very important to recruit the lung, improved, well and good. If not, then if there is no response, we might consider the and the oxygenation index is more than 25, we have to consider other modalities, nitric oxide and HFO, improved, well and good. If not, and the oxygenation index is, there's no improvement, then this is the time to refer. Unfortunately, I mean, we don't have an ECMO center in the kingdom. It would be nice if we do. I don't think I will wait for an oxygenation index of more than 40 because it would be difficult to transfer that patient. But maybe we can develop that service where we have an ECMO not as part of cardiac, but as part of pulmonology, as part of intensive care, in order to provide an extra, access of care for those patients. Time is an essence. Now, how much time would you wait on this or that? Whatever it is, it should not be a long time. And always, we need to ask other colleagues their impression and their opinion as well. Okay, so now let's move to the surfactant. Surfactant replacement. Meconium is known to decrease the surfactant activity by the displacement by direct toxicity of the type 2 neocytes and damage to the surfactant protein A and B. So surfactant, has a role in the Meconium aspiration syndrome, and nearly all the patients that they require ventilatory support, any mode of ventilatory support with Meconium aspiration syndrome, they're going to receive a dose of surfactant. But if we look at the Cochrane review, we find that it's effective in that there is in favor of the use of surfactant and Meconium aspiration syndrome, that it decreases the need for ECMO, which is valid, of course. And the other thing, that maybe it has a tendency to decrease intraventricular hemorrhage, but it really didn't reduce the time, for how long the time of ventilation, like how many days the baby would be ventilated with or without surfactant. Now, the question is, should we give it bolus or should we do a lavage? I think in Hong Kong, they reported the first study where they actually wash they did a wash for the for the alveoli with surfactant. In the past, they used to do a normal saline wash, which was totally unacceptable, because you're going to wash the surfactant in this way if you reach that far down. But lung lavage, they showed that it has an effect. And yes, surfactant is expensive, but their argument that it decreases the length of stay, and if you do a cost analysis, it shows that it does, it is cost effective. But really, other studies did not show that. So it's not really a common practice to do a lung lavage. But a bolus, yes. Now, how often should we do, and the dosing of it? There isn't really a consensus, on it. Now, should we use antibiotics or not? None of the studies demonstrated an impact on the clinical course and outcome in Meconium aspiration infant who do not have very major risk factors for infection, whether they're given antibiotics or not. But usually, an infant with symptomatic Meconium aspiration syndrome are started on empiric antibiotics pending blood culture, and we should really stop the antibiotics if the cultures came back negative for 48 hours. Now, steroids, I mean, if we think of it, well, why can't we use steroids? We know that Meconium activates complement system, and it causes chemical pneumonitis. So why not use steroids? But, according to the Cochrane review, the steroid therapy is not advisable at the present. There is insufficient evidence to assess the effect of steroids, the positive impact of steroids in the management of Meconium aspiration. So it's not really standard of care. Now, persistent pulmonary hypertension, let's talk about this. Okay, so now what happens in utero? You want, in utero, the fetus is not using the lung at all. And, you know, the pulmonary resistance is quite high because, you know, most of the gas exchange happens through the placenta. So there is no need. But at birth, what happened during the third trimester, the pulmonary vascular resistance starts coming down in preparation for, you know, for delivery. Now, and with that, so that when the baby is born and takes that big breath, immediately that high pulmonary vascular resistance will come down and would allow, you know, the air, the blood to go into the lung in order to do the gas exchange because, you know, placenta is not there anymore. Now, if this transition did not happen, and why it didn't happen? Because that fetus could have a very hostile environment in the uterus. I mean, it's been hypoxic, so that resistance did not drop. So, and the resistance of the pulmonary vascular bed, it remains high. So, and you know, that transition didn't happen. So what happened after the baby's born? The baby continued to go through his fetal circulation. Why? Because the pulmonary vasculature here is very high, would not allow the blood to go there, you know, for gas exchange to carry on. So this is what we call it to persistent pulmonary hypertension. And, you know, we have so many other factors. You know, there are, there are pulmonary hypertension that happens without Meconium aspiration syndrome, but it can be, you know, one of the reasons that this fetus has been suffering in a hostile environment, or it could be developmental problems with the alignment between the alveoli and the vascular structure. But whatever the reason is, and Meconium aspiration syndrome, it's kind of failure of transition. Added to that, you know, other factors that the fetus has been exposed to in utero that would not allow that, you know, kind of that reduction in the pulmonary vasculature. So we have a very potent medication that it's actually medication, but also it's endogenously released that causes vasodilatation, which is the NO, as well as we have other medications that act on the same cycle, but NO acts on the granulate cyclase, while the sildenafil acts on the PDE5, and the milrinone act on a PDE3 and causes you know, vasodilatation in the smooth muscles of the vessels, decreasing the pressure, decreasing the vasoconstriction, and you know, allowing air. Sorry, I keep saying air. You know, blood to go into the pulmonary vasculature. So NO can be used, and it's kind of better to use it with HFO. It's more effective in Meconium aspiration respiratory failure. It should be considered if the oxygenation index is you know, 15 to 25. We have, you know, there's different protocols, and we have to have an echocardiography that, you know, kind of shows that there is a persistent pulmonary hypertension. The timely use of NO decreases the need for rescue ECMO and hypoxemic respiratory failure. And the trick as well, with a very important step as well, is when we try to wean the NO. The NO rebound is one of the worst things that you face in dealing with the Meconium aspiration syndrome, added to others. In order to hold the rebound, you need to, rebound vasoconstriction, it should be really done very gradually and patiently. Now, what about sildenafil? We said that sildenafil acts in, you know, in the PDE5 in order to stimulate vasodilatation. Now, There has been a lot of talk about sildenafil. Should we use it? Should we not use it? There was being reported of sudden death. And the NICE review published in 2016 with the systemic review by Perez and Lugon, 2015, the 3 RCTs that were used for the Cochrane review at that time, and they've added also Solis et al. In 2009. The conclusion was, in the resource-limited setting, maybe sildenafil may be a life-saving alternative for neonates with PPHN. But if we have NO and we have HFO, so we better use them. Now, of course, I mean the practices varies, and but if the decision is to use sildenafil, it should be done under the supervision of the of the pulmonologist as well as the cardiology. And this is what we talk about the rationale. And you know what? This is also just to show you that in the severe cases of the Meconium aspiration syndrome, that they have, that the insult has been going on for a while, you see these changes with the echocardiograph. So you see there is an hypertrophy of the right ventricle and also the right atrium, and there is a regurg through the tricuspid valve, which indicates the severity of the pulmonary hypertension. So cardiovascular support is important, because if we go back here, it's important for me to, in order to prevent, okay, so the pulmonary vascular resistance is high, but I don't want as well that the arterial should be low. So I have to pump up the arterial blood pressure in order to prevent shunting of blood from the right to left. So we can use saline boluses, vasopressor for the blood pressure, and or perfusion. But we can use adrenaline, noradrenaline, dopamine, dopamine. People have different experience, and then if you look at the amount of literature and the RTCs saying which one is better. But remember, all those inotropes, they are not really specific. They hit more than the receptors react differently. You could have a vasoconstriction up here. You have an effect on the renal. You could have an effect on the gut. But if you need it, you need it. But people more and more, they are using milrinone, and remember, milrinone, this is how it acts. It acts on the PDE3 in the smooth muscle cells, causing vasodilatation. And the studies show that it is useful. It's an inotropic vasodilator that acts by inhibiting the phosphodiesterase 3 and relaxing the pulmonary arteries. As we've just said, that we need a cardiology help in order to assess, but now also the neonatologists with functional echo, they're able to do these measurements as well. I think we've reached to the end of all the different management that we have. ECMO, like we said, this is not available at the moment, and hopefully we'll be able to do it, with the help of our young colleagues. I want just to end by saying, please be safe. Corona, COVID-19, we need really to remind ourselves that in order to prevent it, simple measures, wash our hands, the cough etiquette, clean, stop shaking hands, and social distance. And